Hi, my name's Kirsten Foote, and I'm here to talk about my practice project that I was trying to integrate into practice for over the past 6 weeks. My project used evidence-based practice through the quality of safety education for nurses, and I tried to better the fall prevention policy. Fall prevention uses fall assessment risk scores, and also it implements interventions. And what I was noticing on my floor and unit, which is the medical surgical acute unit in one of the hospitals, is that we have a wide range, very broad range between low and high fall risk. The interventions were more implemented as patient need versus actual ranges that induce these interventions. So I went through the current policy, and the fall risk assessment, and I tried to make changes to it that would include more information and close those ranges some from being so broad. In some ways, how to close those ranges was to ask certain and specific questions on the fall risk assessment about a patient's need, whether it's their mental status, bathroom needs, visual and hearing defects, nutrition needs, medications that they are currently taking, and fall history. Within these categories, there were specific questions that could help point and negotiate and assess whether a patient has a higher fall risk or a lower one. We also found out, according to the evidence-based practice that I had brought up on a source of Quinley and White's article from 2013, that when nurses apply interventions in a consistent manner, that the standard of care is better protected under a policy and procedure. That being said, it makes it easier. So my idea of having interventions listed for a universal, a low standard, a medium standard, and a high standard. And if you're in the high standard, you would have the interventions from all the previous standards, including the high standard interventions. So it's an umbrella that overlooks everything. I presented this to the nurse manager. They did like the idea. They thought that they agreed that our current policy had a lot of room for error and room for improvement. I had brought the new changes and improvement to the nurse manager. They liked it. When they talked about the budget and financial piece, unfortunately, that is when we could not go forward with implementing it. Although they did agree to allow me to have a fall prevention in service for the floor to help better aware staff of the need and the job that it is a team effort to prevent these falls for patient safety and their quality of care. I look forward to continuing to educate the staff and help prevent patients from unintentional harm that can cost a lot of money with health insurance. So, thank you.